All right, hello everyone. Welcome to the New York Academy of Medicine. My name is Ilana Kiefer and I am the Program Officer for the Center for Healthy Aging here at NIAM. Unfortunately, our president, Dr. Judy Salerno, a leading geriatrician and a strong advocate for advanced care planning, is unable to be with us today, but she sends her regards. Here at NIAM, we are champions for health equity. Our vision is a world where everyone has the opportunity to live a healthy life. NIAM's drive for health equity for all has never been more vital. Because health equity is deeply tied to systemic racism, we actively tackle the issues that are important for social justice in order to advance our mission and promote our vision. Through scholarly, community, and public engagement, we work together to build a more equitable and healthier world for all. Today, we are excited to launch NIAM's new series called What Can I Do?, which will promote positive progress on reducing the impact of COVID-19 on health and racial inequities in New York and across the country as cities begin to reopen. Each event will provide 5 immediately actionable solutions that participants can undertake to make improvements in the program's featured topic. Our first program, 5 Ways to Promote Advanced Care Planning, will explore barriers to creating advanced care plans and innovative solutions for making the process easy and user-friendly, with a focus on closing the racial gap. A huge thank you to Dr. Patricia Bamba, Dr. Martha Sullivan, and Brittany Chambers for presenting to us today. If you would like to ask a question or make a comment at any point, click on the bubble icon below, labeled Q&A, in the bottom center of your screen. Your questions will be shared only with the panelists. So we will start now with an overview of advanced care planning and an explanation of the difference between advanced directives and medical orders with Dr. Patricia Bamba. She currently serves as Vice President and Medical Director for Geriatrics at Excellis Blue Cross Blue Shield. Dr. Bamba also serves as Program Director for New York's Medical Orders for Life-Sustaining Treatment, otherwise known as MOLST, as well as eMOLST, and chairs the National Healthcare Decisions Day New York Coalition. So without further ado, Dr. Bamba, if you can put on your video and sound and share your screen.
Elena, thank you for the kind opening. I am privileged to be here with my fellow speakers to be able to discuss the topic of promoting advanced care planning and to really begin to talk about the differences between advanced directives and medical orders. I do want to start with a reflection for all of the attendees in our audience, asking personally, will you die in a manner that's consistent with the way you lived? Will it respect your personal values, your spiritual beliefs, your cultural background, and preserve your dignity? Ask each and every one of us, have we thought about who we trust to make medical decisions if we're unable to do so? Have we talked to our families about what matters most? Have we put it in writing? And so my hope is that as we think through these issues over the next hour, that each of us will have that opportunity to do so. I want to talk a little bit about the ideal advanced care planning conversation as defined by the Institute of Medicine's Dying in America report from 2015. And that's that This is a conversation that occurs with that trusted person that would make decisions if you were unable to do so, the primary clinician who you trust, members of their team. It's put in writing, it's recorded, it's updated periodically, but it allows for flexible decision-making in the context of where the patient is along the health illness continuum based on their health status, their prognosis, and what matters most to them in terms of their goals for their care. Advanced care planning is a process, and it begins when people are healthy. And if we wait in the illustration in this rainbow until people are at the time of death, it's a very difficult time to begin that conversation. We've seen with COVID how difficult it is, and more difficult because of the inability to be face-to-face with individuals, but the emotional toil on families at that time and loved ones is incredibly intense. So the goal is to really start ahead of time when people are healthy and to recognize that this conversation needs to occur over the life cycle, from starting when people are 18 and ending when they're near end of life. There are two different kinds of documents that are created as a result of the process. For everyone 18 and older, we need to focus on a healthcare proxy. It's the legal document in New York State, and it identifies who the person is to make the right decisions and stand in your shoes and do decisions in accordance to what you would want, not what they would want for themselves. And all of those decisions are made once there is a legal document under public health law. That individual must, in the document, you must identify your preferences about artificial hydration and nutrition. And it's best to not be specific as much as to say my agent or my healthcare agent knows my wishes about artificial hydration and nutrition. Living wills are difficult to follow because so often there is potentially reversible illness and an irreversible condition such as end-stage Alzheimer's disease and a potentially reversible pneumonia. And we heard those stories from individuals in our community 20 years ago, and we developed medical orders for life-sustaining treatment, building on New York State's Do Not Resuscitate law, which was the first in the nation, and adding other important conversation and medical orders related to respiratory support, hospitalization, and other life-sustaining treatment. Resuscitation, respiratory support, and hospitalization were found to be most important during COVID. There are 5 easy steps to thinking about advanced care planning, and it's based on behavioral readiness for us to change and do healthy behaviors. As we look at this, it's based on the behavioral readiness for us to change other things like quit smoking. So the first and important point is actually learning about advanced care planning and advanced directives, which you're all doing today. The second is to identify and remove barriers to understand why you haven't done it, if you haven't done it. And then the third is to motivate yourself. And it comes from personal stories. We have a whole host of videos in the YouTube channel that I'll mention later that help you to begin that storytelling as a place to begin that conversation. And then it's really to complete your healthcare proxy. And it starts by having a conversation with those trusted individuals, choosing the right healthcare agent, talking about what matters most, understanding life-sustaining treatment, but not focusing on that as much as what matters most, your values, your beliefs, putting it in writing, and then sharing documents, and recognizing that this is a process, and what matters most at 18 doesn't matter the same at 25, 35, and certainly not 85. And so it's a continuous process that needs to be reviewed and updated. There are multiple stories that we have, and for the sake of time constraints today, I'm just going to tell you the story of Bill and Debbie, where they did have this conversation. And because of that conversation and putting it in writing, the patient's wishes were honored and the family was at peace. And as Bill says, talking about dying doesn't mean it's going to happen. as opposed to my friend whose family did not have a conversation, and her aunt suffered and the patient suffered for 3 months as he was on life support and were immobilized in terms of making decisions, and her aunt suffered for years to come. The story about another friend of mine, another colleague, whose story illustrates the ability to choose the right healthcare agent and talk about what matters most. And when she had an acute illness and had a major stroke and had a bleed in her brain, her family knew what mattered most, her independence. And her brother was able to make the decisions, and she's still living independently. So advanced care planning and doing a healthcare proxy is not just about death and dying. It's about people who have an acute illness, such as COVID. People lack the ability to make decisions, and the patient recovers. Similarly, for Lee, whose wife became acutely ill, and 6 months after they were married, she ended up needing to be in an induced coma. The conversations that he had about what mattered most to her helped him to navigate the decision-making and to help his new stepchildren through that process. And my friend Lucia, who basically talks about her sister's story, who did not have a healthcare proxy, had an acute abdomen, needed surgery, and just before she went into the OR, completed a document that appointed a healthcare agent. They had a brief conversation, but when she needed to have, again, be induced into a coma, through the grace of God, she survived, but her family was able to make decisions in accordance to what mattered most to her. And as a result, she had discussions with her children about what mattered most, put it in writing, and did a healthcare proxy. So that's for all of us, and there are medical orders that are appropriate for those that are really sick. It's not for everyone. It's not an advance directive. It's a set of medical orders where the physician basically would not be surprised if the person dies in the next year, or their nurse practitioner, or recently, as of June 17th of this year, public health law changed to also include physician assistants. It's for people who live in a nursing home or receive long-term care services in assisted living or at home. And increasingly, we know that's happening with COVID, and many people are not going into long-term care facilities. It's for anyone who has advanced age who says, there are things I want right now, there are things I don't want. I heard that in my practice, where someone would say, it's okay if I die in my sleep. I don't want to be suffering on a ventilator and have my family see me suffer. And it's for people who have advanced chronic illness or a new condition that they will not survive and they have a poor prognosis. Or it's for people who are repeatedly coming in and out of the hospital and they have more need for social support out in the community, and these admissions are unplanned. So MOLST is not only a bright pink form, it is a process of communicating. It's talking about what matters most to individuals in light of the patient and their family understanding their health status and prognosis and their goals. It is a set of portable orders that is available across care transitions from one setting to another and need to be followed under public health law in all settings. And it's the only form that EMS can follow both do not resuscitate and do not intubate. And a palliative care plan needs to be available and caregiver support to be able to make sure that MOLST is followed. There's a protocol that is followed. It's only step 7 when you actually complete the MOLST form. There is a whole set of legal requirements that is outlined by the Department of Health, 5 for adults, 1 for children, and a special process for individuals with intellectual or developmental disabilities who lack the ability to make medical decisions. And these decisions must be followed before the MOLST can be signed. And for that population, only the physician can sign MOLST orders. The important piece is really talking about what matters most as part of this process. Once the individual understands and accepts they're appropriate for MOLST and wants to proceed, because completing it is voluntary. The goals must tend to align with wanting more time or longevity, wanting to preserve their function, age in place, for instance, at home, or to be able to manage to just focus on comfort measures, their dignity. Shared decision-making is important for each element on the MOLS form. And it's important for our decisions upstream. Do we want to have specific surgery, medical treatments, chemotherapy, a lab test? Will that treatment or test make a difference? How will it help? How will it hurt us? Is there hope of getting better? And if there is, what's life going to be like if you do get better? Because if you don't know that, it's hard to know what to decide, because the fourth element is most important. What does the person value? What's important to them? Understanding how these medical orders will impact you, if there is, if you are at end of life, is very important in terms of understanding whether it's going to work or not. The resuscitation for someone healthy and the survival rates are not the same for people who are appropriate for MOLS, where it doesn't work with advanced illness. It wasn't meant to stop death. The same holds true for respiratory support and decisions about hospitalization and transfer. Advanced care planning is a key pillar of palliative care, but the care plan needs to really look at the other two key pillars: pain and symptom management, and support and education for caregivers and loved ones and staff during these very challenging times. So to summarize the difference, everyone gets all treatment. If we have an acute emergency, EMS is called, we receive all treatment until the doctor assesses the situation, talks to the healthcare agent or surrogate under public health law, and full treatment is continued until there is a decision to stop a life-sustaining treatment. So that's standard care. Everyone gets all. During an emergency, advanced directives cannot be followed by EMS. And so with most, when there's an emergency, EMS is summoned. EMS will assess on site at the patient's home, nursing home, or assisted living. We'll look on the refrigerator or in other areas in an assisted living, for instance, or a nursing home, or those most orders. And if the person doesn't want to go to the hospital, they will make sure that the palliative care plan continues. If they want to go to the hospital, then the physician has the opportunity to know what the medical orders are and is able to either continue the treatments that the person wants, but if palliation could not be honored at home, they will continue and be admitted for palliation. Pre-COVID, all of these discussions were face-to-face, and we know that with COVID, there's been a shift to telemedicine, and for that, there is an appropriate digital transformation. eMOLS is best practice. It's a secure website. There's a standardized process for online completion of MOLS, which is also a registry for all of the forms across New York State. It improves quality, patient safety. It guides everyone through the conversation. It integrates that 8-step protocol, all of the legal requirements that are there for patient safety, and it allows the physician, nurse practitioner, or PA to sign it. It's automatically part of the registry. It's a free public health service that was invaluable during COVID-19, particularly in New York City. There are a host of resources that you can continue to learn about advanced care planning. There is a website, which is a community website that has been around for 20 years called compassionandsupport.org. It was redesigned 2 years ago to have a sister site, mols.org, to learn more about the MOLS program. There's also an incredible YouTube video that will help you to see how we can continue to move this forward. There's a program that we have done in Rochester, New York on community partners in advanced care planning between our Black ministers and our nurses to continue to move this process forward. Advanced care planning is a plan for living. As Dame Cicely Saunders says, you matter because you are you until the last moment of your life. We'll do all we can help you not only die peacefully, but truly to live until you die. I don't have time for a personal story, and I can reflect on that if there's time after our other presenters. Thank you for your time today.
Thank you very much, Dr. Bamba. You put so much information into a short period of time, and I really appreciate what you taught us. We're now going to switch gears and hear from Dr. Martha Sullivan, and she will be exploring some reasons for particularly low advanced care planning rates in the African American community. So Dr. Sullivan, you can show your face and your voice and share your screen. Beautiful.
All right then. So can you hear me? And
yes,
see?
we can hear you. Yep.
There
Beautiful. Yep, you're good.
So I too would like to thank the Academy for this important presentation and thank my colleague, Dr. Bamba and Ms. Chambers for this fascinating and important work that you've been doing in this issue. I'm going to speak about ways that we can advance care planning for African Americans. I find it important to start by giving the context that actually far too many Americans in general are not taking advantage of the opportunity for advanced care planning. And even fewer African Americans are doing so. In fact, when we look at the advanced care planning by Americans nationally, 1/2 to 2/3 of all Americans do not have an advanced care plan. When we look at what are the obstacles for African Americans, I think everyone has heard at some point, oh, there's a concern about lack of trust in the healthcare system. I'm going to suggest that we look at the healthcare system and see what are the systemic obstacles that create that lack of trust in African Americans. And then look also beyond those systemic issues to what individual providers, I understand there are many providers in the audience, so we'll talk about what you actually can do even as a provider to enhance African American use of advanced care planning options. And Dr. Bamba just went through what some of those are: having a living will, having appointed a durable power of attorney or proxy, and having discussed preferences with a loved one. Now, one of the things that we find is that African Americans are taking advantage of all three of those options less than white Americans. However, the difference in the use of the discussion with their loved ones of preferences, the difference is not so great. Now, we know from our understanding of Black culture the importance of family and relationships. So more of us actually do talk to someone about what we would like. Dr. Bamba mentioned, and I'm going to underscore this, we also need to pair that conversation with the written document, right? We need to have the conversation, but also write down what we wish so that we can assure our wishes being adhered to. We've all heard, we know why this is important. We've all heard the adage, failing to plan means planning to fail. So I won't dwell there much longer, except to say that if we really want to be sure that our end of life is the way we anticipate or envision it, this becomes very important. And I will also add that many of us think of life and death, that dichotomy. But we should also think about decisional capacity, right? So some people are actually looking at presently that dying is a more protracted process due to healthcare advances. So even the term having a slow medicalized death, and that might include loss of decisional capacity. So when you think about it that way, I'm sure all of us can think about the situations we've been involved in where the person was healthy in some ways, but in others was not able to make decisions for themselves. And that's when you really want there to be some way of knowing what that person would want for themselves. It matters because also, according to one study by the Pew Center, and I quote, African Americans do tend to die more often on machinery, in facilities, away from home, and in pain than white patients. So when we look at the systemic issues, because again, that's a behavior or an approach you're seeing in a cultural group, but what are the systemic issues that have created that reluctance and that lack of trust? Everyone's heard about the Tuskegee study, I'm sure. But I would urge you, if you can take the time to really look more closely at what that study was about, I can assure you that you will be appalled. These men were not, it was not only that treatment was withheld from them, they were lied to. They thought that they were being treated. The efforts that were gone to by the researchers to see to it that they were not treated were very aggressive. Treatment was withheld from them in other sectors of their life in order to preserve, unquote, the integrity of the study. I could go on and on about the Tuskegee study, and I have to refrain in the interest of time. But know that these men died very unnecessarily, that it was sponsored by the government, and there were racist beliefs that undergirded the whole study. The study was to compare how the course of syphilis would reveal itself in Black men compared to whites. There was the notion that they didn't seek treatment because they were stoic. They really didn't seek treatment because it wasn't available to them. And quite frankly, they very much trusted the healthcare system and trusted the fact that this was a government-sponsored study and thought that this was an opportunity for them to get care. Henrietta Lacks and her family also trusted the healthcare system. You have probably heard about the immortal cells of Henrietta Lacks. So her cells were cultivated without her permission, and for 60 years, these cells have continued to grow. There have been billions of her cells called HeLa, an abbreviation for Henrietta Lacks. And these cells have contributed to treatment, understanding treatment of cancer and viruses, contributed to developing the polio vaccine, in vitro fertilization, gene mapping, on and on. Yet her daughter would ask that if her mother was so important to medicine, why couldn't her children afford healthcare insurance? One might ask also, why was she buried in an unmarked grave? Both instances of people presenting themselves to the healthcare system with a certain amount of trust and expectation, and it was the system that let them down. So we can also think about what's in the news presently about immigrant women being forcibly sterilized, and these are women of color. So we have these historical atrocities that have occurred, but we need to look at our current healthcare system too and see where are the disparities and medical racism that still supports a lack of trust in Black patients. So just for example, there are so many studies that show that African Americans receive poorer quality health care. There's actually research, you may have heard about this in the news most recently, showing that the health care Black Americans receive is actually better when they're treated by a Black physician. And actually, a philanthropist that you all would know very well is actually funding the study of Black physicians at 4 of the major Black medical schools for this reason. So the healthcare system today is really challenged to deal with this healthcare disparities that are rooted in systemic injustice. And the one quote that I must read to you because I think it is so telling from Alan Elbaum. He says, if George Floyd had died of COVID-19, the world would not know his name. If he had lived another 30 years and died of cardiovascular disease, the world would not know his name. Yet, if he had died at age 74 from diabetes-related complications, the underlying cause of death would be the same. It's racism. So even in today's healthcare system, African Americans die an average of 3.5 years sooner than whites. Infant mortality rates for African Americans are twice as high as for whites. For people who want aggressive treatment for cancer, whites are more likely to receive that preference. When we look at mental health, Blacks who present with symptoms of a mood disorder or PTSD are more likely to be diagnosed as schizophrenic. African Americans are also more likely to be referred for inpatient mental health care than outpatient care. And we certainly all know that the morbidity and mortality rates for African Americans with regard to COVID-19 are 2 to 3 times our representation in the population. So we need to really focus more on dealing with disparities and providing care that is culturally appropriate. And part of that is understanding cultural and religious beliefs. There's much that can be said here, but I'm going to sum it up by saying if you look at 3 major religious traditions, Catholicism, Islam, and Judaism, you will find that they all have positions based on their theology on suffering, ordinary versus extraordinary means, provision of hydration and nourishment, and withdrawing life-sustaining equipment. You would be surprised to see, despite slight differences in perspective in terms of the expression on these issues, they are all remarkably similar. They all address some place for suffering. They all actually require and see as a moral obligation to provide ordinary means. That means people should not suffer unnecessarily. People should be supplied with nourishment and hydration. But they all also speak to the fact that hydration and nourishment can become extraordinary, right? So if hydration and nourishment is applied when there is very little ability for the patient to assimilate it physically because they are really actively dying, or it would cause more agitation and suffering to the patient than the benefit that it would supply, that actually becomes extraordinary. And all 3 of those major religions do not require extraordinary means. They may not prohibit it, but they do not see that as a moral obligation. This is very important because we know for African Americans, 70% of African Americans will describe themselves as being religious or say that faith is very important to them. We also very much trust our religious institutions and clergy, so we can see clergy as a resource to the provider. You might actually reach out to the clergy yourself or encourage the patient to do so. Family, of course, is also very important. And again, often the discussions and preferences have occurred with within the family, but that also needs to be documented. And doing so actually helps the family. It's a relief to the family to know, and to know conclusively, because it's in writing, what their family member actually would have wanted. It's important, going back to religion, to understand that your patient might have more faith in God, because holding on to hope is just so central to the African American experience, given the experience over generations of oppression, where hope is what kept people going. So we talked about all of the systemic issues. My colleague, Brittany Chambers, is going to talk more about those and give specific ideas about what we all can do, how we all can advocate for policy changes. But let's talk about what you as a provider can do that's fully within your control. And I would say two categories: relate and advocate. Good communication leads to a positive relationship, which engenders trust. You want to have a good relationship, a trusting relationship with your patient. Communicate with them. Communicate in a way that people feel that you are experiencing them as a whole person, not simply a patient. Ask about their family, their job, their kids. Maybe share a little bit about yourself. And trust me, I understand you've got maybe 15 minutes with a patient. I really highly recommend the article mentioned here, Conversation Starters. You'd be surprised the little things that you can mention to engage a person that lets them know you genuinely care about them. That's what builds trust. African Americans are reporting that this is an issue, poor communication with their provider. Give information. Hospice care, which is an option that most Americans, well, I should say in general, Americans are not taking full advantage of. African Americans are taking even less advantage of, because there's less information provided to them about hospice care, which could be at home, which could be in a hospital, and which keeps a patient comfortable and provides for psychosocial support for them and their family if they are dying.
Just one minute, Dr. Sullivan. We just have to wrap up, okay?
And lastly, advocate. Advocate for the big policy issues that you're going to hear more about, but also raise your voice and your hand in your organization about inequity, about disparities in care, some of which you may see, some of which have not been unearthed. If your organization is not seeking to identify disparities in outcomes, they should be. So offer yourself to help with that. Work with other professionals on these issues and participate in the life of the community. When your patients see you in the community, at events, at celebrations and so forth, or just walking around the community, that gives another sense of your respect for them and understanding of them, and creates more of a willingness of them to feel that they can trust in you. So there's so much more that could be said, but I will end with a quote that says, "Speak of death," and I would add incapacity, "in the time of life." And I would also add, "and write it down." Thank you.
Thank you very much, Dr. Sullivan. And I realized I forgot to actually say what you do for a living. So Dr. Sullivan is the executive director of the Creedmoor Psychiatric Center, and she's also the vice chair of the NIAM Fellows section on healthy aging. So thank you very much for sharing your words. And our final presenter is Brittany Chambers, who is going to give us 5 potential solutions to promote advanced care planning and help to close the racial gap in this area. Brittany Chambers is Associate Director of Education at CAPC, the Center to Advance Palliative Care, which is an affiliate of the Icahn School of Medicine at Mount Sinai, right here in New York City. Take it away, Brittany.
Thank you so much, Alana. And I just want to thank Dr. Sullivan and Dr. Bamba for their phenomenal foundational presentations before mine. So I also want to thank the audience. Thank you all for being here with us today to learn more about ways to promote advanced care planning. And I just want to acknowledge that my past experience as a health disparities researcher and just my values around social justice have aligned with the work that I do at CAPC to help ensure that high quality palliative care services are accessible and equitable. Within that lofty goal, advanced care planning is very important. As Dr. Sullivan so eloquently laid out the number of challenges to advanced care planning completions for the African American community. So I usually like to start off my presentation with just describing what palliative care is. Because there are sometimes some misconceptions about it. And so I just want to acknowledge that palliative care is a specialized, a specialty for individuals who are diagnosed and living with serious illness. It is focused on providing relief from the symptoms and stress of the illness. And overall, its goal is to improve quality of life for both the patient and their caregiver. Palliative care is traditionally provided by a team of doctors, nurses, and social workers. And they basically work with a person's primary care provider to provide an extra layer of support. And then finally, just want to acknowledge that it is appropriate at any age or phase of a person's diagnosis and can be provided alongside curative treatment. Palliative care, like a number of studies have shown just how impactful that it can be in reducing symptom burden and just improving quality of life. How this relates to health disparities is because there are a number of groups who have traditionally been oppressed and have had really traumatic experiences with the health system, as Dr. Sullivan explained beforehand. And so palliative care and having a positive encounter can kind of counter those narratives and experiences. And I briefly just want to talk about CAPC, Center to Advance Palliative Care. So we are a member org and we provide tools and training to 80,000 clinicians across the country. And we do it in a number of ways. We provide quality content around the sustaining palliative care programs. We convene health plans and ACOs around ensuring financing for palliative care teams. And then we also provide training for clinicians. And I just want to acknowledge that we have a number of communication courses focused on clarifying goals of care. And then we recently partnered with the Respecting Choices organization to provide 3 online advanced care planning conversation courses that are free to CAPC members. So now I'm going to go ahead and delve into some of the ways in which staff who interact with patients can help increase rates of ACP for African Americans. And so first, I just want to acknowledge that it's important to identify the opportunities to introduce basic ACP for patients who have not either started engaging in the process or who may have not even thought about what this even means, and there are particular groups, as mentioned before, who are particularly should be involved in the conversations, whether they have a serious chronic illness or they're experiencing any type of complications. These conversations are super important. And then for the African American community, just want to acknowledge that we have learned that starting with a broader view of what advanced care planning with a little bit of less emphasis on the form itself at the beginning of the conversation can be helpful, really just clarifying that advanced care planning is really trying to understand what the fears, hope, and preferences are for all parties. And the message is that through a thorough conversation and ongoing conversations, you can solicit the information that's needed to then go ahead and complete a formal document. And so there are a number of replicable interventions that use clergy and community members to help increase awareness and stress the importance of advanced care planning conversations for the African American community. I want to acknowledge Danetta Sloan, who's a social worker at Johns Hopkins University. She's actually at the moment partnering with Black churches in Baltimore and Washington, D.C. to develop and evaluate faith-centered approaches and advanced care planning aids. In California, we have the Alameda Care County Alliance, which is a faith-based lay navigation program serving predominantly African American adults with advanced illness. And through their churches, they're able to have kind of a partnership between aligning their care preferences with their spiritual and religious values. I would just want to acknowledge that, using a non-traditional clinical team can help to bridge the gap between the healthcare delivery system, community organizations, and faith-based communities. As trusted members of the community, these lay navigators can help to link community members' needs with resources in their own community. And then they also can provide like that additional time, dedicated time to acknowledge and increase awareness around what advanced care planning truly is. And then finally, I just want to acknowledge that, using these other trusted community members can help address health literacy issues, for example. Most of the time in the medical community, medical jargon could be used, but through using a lay navigator, you can start to have those initial conversations using plain language and start to get at some of those barriers that may be there. I know this has been touted before, but I just want to also emphasize again the importance of well-trained and comfortable conversations. Especially in those initial conversations, they're so important, especially as a person's disease trajectory changes over time. Unfortunately, in the literature, we know that we've seen that in serious illness conversations between doctors and Black patients, it's less likely for their care to result in things that are consistent with what they actually prefer, which can be attributed to a number of things, but probably implicit bias is a big factor. And so some of that can actually be mitigated through thorough and intentional conversations that will lead to the completion of the advanced care planning form. And then for staff that are, not as comfortable in initiating the conversation because we acknowledge that they can be challenging, we also emphasize the need for using some, as Dr. Sullivan expressed, like conversation starters or scripts. We know Vital Talk has helped in developing materials. Specifically during COVID, they created one that would help with having conversations, particularly with the African American community. So for example, you can see in the bubble, a patient may say that one of their family members had a negative experience with the medical system. And so it's up to the staff person to then delve a little bit more into understanding, well, what exactly happened, because in doing so, you get to learn a little bit more about, some preconceived notions and really start to break down some of those walls. Also want to acknowledge the importance of, exploring the meaning and words of phrases of what's happening in the conversation. The research shows that Black patients report being less satisfied with their experience or care if the clinician is more verbally dominant in the conversation. So it can't be overemphasized the need to have ongoing reciprocal and two-way dialogue so that you can learn from the patient exactly what they're feeling and again, what their values truly are. And then last, just want to acknowledge that it is important to, again, identify and address any barriers because, you may uncover that like they're afraid to talk with their family about these issues, or they're just lacking some information about what it is. And so, rapport building and digging deeper can really help with establishing trust, as I mentioned. Again, I can't reiterate enough about the importance of the trusting relationships Dr. Sullivan so eloquently expressed, because of the medical system's past and current. I think we can say, negligence, there are some notions about having these conversations and about putting things formally in writing. And so I think, again, the conversations and the really rapport building cannot be overstated. They really help to, again, break down barriers. And then even just framing the form as a method of showcasing that, you know, we really do want to align with what you really would want, and that we're trying to use this as a tool so that your wishes can be met to the extent possible. And then this is just a screenshot of an example from Ariadne Labs, where it was a conversation between an NP who called a long-term care resident's husbands to kind of like ask him a little bit more about what that resident's values were, what she would have actually wanted. You know, she can't make decisions for herself at the moment, like you guys have had conversations in the past. So what would she be fearful of, or to what extent would she want, life-sustaining measures and that sort of thing. And then again, I want to also emphasize that this is not a one and done. These conversations about hypothetical scenarios are hard to implement when a crisis hits, and that people's wishes will change over time. And so it's just important, if you're in a clinical setting, to just always make sure that people's forms are up to date, because their preferences, again, as their disease trajectory can change. And also, if the initial conversation doesn't result in the completion of a form immediately, following up with additional information so that they can explore and learn more on their own. And then when they're ready, through other mechanisms, if they wanted to do it with their proxy, they could either do it through eMOST or whatever type of form virtually. And so it doesn't have to happen in real time, as I expressed, just building that initial relationship of breaking down barriers first. And then lastly, I want to just advocate again for the state registry for advanced care plans. We know here in New York, eMOST is a great example of how, you know, it's able to be easily accessible across to care settings and by multiple providers. And so just a seamless way so that patients' preferences can be realized to the extent that they can. And just a call to action that this is everyone's responsibility, these conversations, the initiation of them. We can all contribute to helping to increase the completion rates for the African-American community. And then so I'm running out of time, and I definitely want to make sure there's time for question and answer. So I just want to thank everyone for their time. And there is a CAPC COVID response resource hub with a dedicated tab on communication tactics and guides and materials. And if anyone wants to contact me directly, my email address is listed on this page. And thank you.
Thank you so much. All right, so we unfortunately do not have time for Q&A now, because I just want to tell you about a few events that are coming up at NIAM. But we will make sure to send you all of the materials, and I'm sure that all of our panelists will be happy to communicate with you ongoing, because I know it's a topic that's obviously near and dear to all of our hearts. But I just want to thank you all as the audience for attending, and to our panelists for joining us and for sharing your work and your thoughts. As I said, we'll be sending out a lot of information, including these 5 actionable items. We hope that many of you will join us next week as we continue our exploration of race and health in a historical context. We're going to be exploring the ongoing challenges that are laid bare by the COVID pandemic. On the afternoon of October 1st, NIAM is hosting an event called Black Maternal Health, Historical and Reproductive Justice Reckonings, which will feature historian Deirdre Cooper Owens and activist and scholar Lynn Roberts in a program co-sponsored by the Consortium for History of Science, Technology, and Medicine based in Philadelphia. You can register for this free event at the Academy website at www.niam.org on the events page. And we will also continue this conversation about end of life on October 28th at 4 p.m. with an event titled A Dialogue About New York's Medical Aid in Dying Act, which will be co-hosted by End of Life Choices New York, as well as the NIAM sections on nursing and healthy aging. And finally, We will have more What Can I Do events in the near future, so please stay tuned. So I just want to thank you all and enjoy your lunch, and we'll see you at some more NIAM events. Thank you.